Hello, anesthesia enthusiasts, and welcome to another episode of Style Points. I'm your host, John Crow. Today on the podcast, I'm sitting down with Dr. Mike Wenninger, the Director of Animal Health at the Cincinnati Zoo, to talk about what anesthesia looks like when your patients include fish, penguins, venomous snakes, and elephants. Longtime listeners may remember episode 5, when my colleague Brian Vaughn told us about doing anesthesia for the gorillas at the zoo. Before we get there, I'll hand it over to my co-host, Nate Moore, to introduce this month's RSI, which of course stands for Resident Selected Information.
Thanks, John. I'm welcoming Dr. David Karngba back to the program. You last heard from him as an intern, and we're lucky to have him back as a brand new CA1. He's gone above and beyond digging into an emerging concern regarding anesthetics in patients with Venezuelan ancestry, so this will be important to listen to before you do your next pre-op. Welcome, David.
Hi everyone, this is David, one of the anesthesia residents here at UC, and today I wanted to talk about an emerging patient safety issue that's generated a lot of discussion in the anesthesia community over the past few months. Recently, anesthesiologists around the world started noticing healthy children and adults developing devastating neurologic injuries, including strokes, prolonged coma, and even death after routine anesthetics. It started with reports from anesthesiologists in South America that were believed to be isolated events, but as word spread through the anesthesia community, additional similar cases were identified in Europe and the United States. As investigators looked more closely, a pattern began to emerge. Many of the affected patients shared one important characteristic. They were of Venezuelan maternal ancestry. Family histories also revealed that in several of these cases, relatives had also experienced similar unexplained complications after anesthesia. That observation prompted genetic testing, which identified a mutation in mitochondrial DNA involving the ND4 gene, a gene responsible for encoding part of complex 1 of the mitochondrial electron transport chain. So what is the significance of this? Well, complex 1 is responsible for the first major step in oxidative phosphorylation and the generation of ATP, which our cells are dependent on for energy. The brain is especially dependent on continuous ATP production, and volatile anesthetics are actually known to inhibit complex 1. As a result, the leading hypothesis is that patients carrying this mutation may have mitochondria that function normally under everyday conditions, but become unable to meet the brain's metabolic demands when exposed to these volatile anesthetic agents, resulting in profound neurologic injury in an otherwise healthy patient. It's important to emphasize that this mechanism is still under investigation. We don't know exactly yet why these complications occur and why only certain individuals appear susceptible. We also don't know which anesthetic technique is truly safest, as propofol can also affect mitochondrial function, although the relative risk between volatile agents and propofol in these patients remain unknown. To date, only about 36 known or suspected cases have been reported worldwide, making this an exceptionally rare phenomenon. However, because of the severity of the outcomes, the American Society of Anesthesiologists and the Society for Pediatric Anesthesia felt the evidence was compelling enough to issue a joint communication to practicing anesthesiologists. First, they encourage anesthesiologists to ask patients about maternal Venezuelan ancestry when obtaining a preoperative history. Because mitochondrial DNA is inherited exclusively from the mother, maternal lineage is particularly important. They also emphasize approaching these conversations with sensitivity and making it clear that the questions are intended solely to identify patients who may benefit from additional evaluation. Even more importantly, a negative family history doesn't eliminate the possibility of risk. Because mitochondrial disorders can have variable expression, someone may carry the mutation even if no relatives have experienced complications. For patients considered at risk, consultation with genetic specialists and consideration of targeted testing for the specific ND4 mutation may be appropriate. The next recommendation is in regard to anesthetic management. While we still don't know the safest anesthetic technique for these patients, current expert recommendations are to avoid volatile and inhaled anesthetics when possible and consider regional anesthesia if it's appropriate for the procedure. Additionally, they also recommend employing process EEG monitoring such as a BIS or SedLine throughout the perioperative period in order to avoid burst suppression. It is also worth noting that a few patients reportedly underwent propofol-based anesthetic without complication. However, propofol can also inhibit mitochondrial function, so we simply don't have enough evidence yet to conclude that it's the safer alternative, particularly for prolonged infusions. We can consider the use of agents such as midazolam, dexmedetomidine, and ketamine, which have not been associated with complications in this population. Finally, if a suspected case does occur, anesthesiologists are encouraged to report it through their institutional patient safety systems and the anesthesia incident reporting system so that additional data can help guide future recommendations. Overall, anesthesia has always been personalized based on a patient's physiology, medications, and medical history, and increasingly, we're seeing that genetics may just become another critical piece of that puzzle. Just as malignant hyperthermia changed the way we think about inherited anesthetic risk decades ago, the emerging mitochondrial disorder reminds us that our understanding of pharmacogenomics is still evolving. As more cases are identified and studied, we'll hopefully gain a clearer understanding of which anesthetic techniques are safest and why these complications occur in the first place. Until then, awareness, thoughtful screening, and continued reporting of suspected cases remain our best tools. Thanks for listening.
Mike, thank you so much for joining us. Before we get into it, let me ask you one of my favorite interview questions, which is my dinner question. If you could have dinner with anyone in the world, could be somebody from the past or even from fiction, who would it be?
Well, I'm not someone who is really awestruck by celebrities or anything like that.
Sure.
I kind of just, I'm a herp guy. Like I like reptiles a lot. So I'll use the cliche answer and say Steve Irwin.
That's fantastic. Tell me more. What would you talk to him about?
Well, I would ask him how it's so easy for him to find the reptiles, because when I look, it takes me forever to find a single specimen. And it just seems like every time he looks anywhere, there's one there. So I also kind of think they were planted.
Oh, yeah. I imagine so. It would be really interesting to get behind the scenes with Steve Irwin. I heard his son does a lot of stuff too.
Yeah, I haven't really paid much attention lately, but yeah, I know he's kind of carrying on the legacy.
So speaking of herpetology, I read that you found your first snake when you were 4, and you've just been all in after that. Can you tell me more about that story?
Yeah, my parents made the mistake of telling me when I was a little kid that if I could find a snake, I could keep it. And I didn't stop looking until I found one. I found a baby red-bellied snake, and at the time it was, before internet, so we called the local like DNR people and said, "Hey, what do these things eat?" And they're like, "Flies." I'm like, "That's cool," because they don't really like that's so it didn't live long. So maybe that's what changed or helped me to be where I am now. I don't know, but now I like to fix things because I obviously when I was 4 really messed up, or my parents did.
So tell me more about how you came to pursue veterinary medicine and how you became who you are, and tell us who you are, what you do and what your life is like. A big question.
Yeah. I've always loved animals, and which is also every single veterinarian will tell you that. But I also really like fixing and figuring out problems. So I knew I wanted to do medicine. And it just was a natural fit. I had at one point thought about doing human medicine, but then I realized that humans are gross and animals aren't, which isn't entirely true. A lot of animals are also gross. So I just decided like that would be the path I wanted to pursue. I grew up, and my family didn't have much for money, so I wasn't able to go from vet school to multiple internships and then a residency and then become a zoo vet. So I took the very scenic route to my career. So I grew up, went to undergrad at UW-Madison. I was there for 3 years. I got into vet school a little bit early, which helped save money.
Mm-hmm.
Went to vet school at UW-Madison and then went into private practice and did exotics and companion animals for about 14 years before deciding I wanted to make the switch to full-time zoo.
So how did you get into a exotic animal private practice? That seems interesting. I don't know how any of this works.
Well, if you're willing to see them, not a lot of people are. Well, now more people are, but at the time there weren't a lot of people really interested in treating birds and reptiles and small mammals, and a lot of smaller zoos couldn't afford to have a full-time veterinarian on staff, and so I worked for a bunch of smaller zoos just to help provide care for their collections. And so I got a ton of experience that way. about 40% maybe of my clinical caseload were exotics for 14 years. So a lot of patients then. And then was lucky enough to get a position out in California at the Fresno Chaffee Zoo, and was there for 4 years. Saw the position open up here, and I really wanted to get back to the Midwest. I'm from Wisconsin, wanted to be close to family. The zoo here is awesome, and it's one of the best zoos, and it's a great position. I have all the support in the world, and yeah, I love it here.
I can confirm that the Cincinnati Zoo is awesome. I have the whole family membership and everything else. So I love walking through and seeing all the animals, especially having been given the opportunity to take care of a couple of the gorillas here. I wonder if you could talk a little bit about the partnership that the UC's anesthesia department has with you guys and what we do with you.
Yeah, it's a great partnership. So we we kind of have to know about anesthesia for all the different species we have, everything from like our insects and fish and amphibians, reptiles, birds, mammals, all the things. And the one like group of animals that we see here, that there are people who are obviously better or more knowledgeable at, would be our apes, because they're so closely related to people. So for any kind of longer or more involved procedures, it's nice to have human anesthesiologists here who can treat these guys more similarly to a human than to most of the other animals that we work with. So it works out really well. And yeah, everybody's been super accommodating, great partners.
So with Gladys and her broken arm, I remember talking to my colleague, Dr. Brian Vaughn, about it. And he told us about the conversation about whether or not to do a nerve block, and ultimately decided not to because Gladys wouldn't really understand with her arm being numb. I wonder, from your side, what was that thought process and conversation like?
Well, I think we just didn't know how she would respond. I wasn't 100% against doing nerve blocks. It's just sometimes if they can't feel it, they might like chew at it, or she was already hurting a lot. So we did provide a lot of analgesia for her. So she didn't seem painful post-operatively. So it worked out really well. I think there were also local blocks like at the surgery site and things like that.
Yeah, that makes a lot of sense. I have to name check another famous Cincinnati animal. I wonder, have you gotten the chance to work on Fiona before? Is that one that you're pretty familiar with?
Yeah, I think everybody in the zoo is real familiar with Fiona. She's a little bit of a diva, and she kind of does what she wants. She's actually really well trained, and her keepers are great with her, and so along with the rest of the hippos. But so she's trained to let us get blood from her, do exams like oral exams and ear exams, and we can ultrasound her abdomen. It's a little tough because she's quite thick.
Yeah, I imagine.
But yeah, we can do a lot of diagnostics with her. The only thing we've had in the last few years with her is when she cycles, she gets a little hormonal. So sometimes her attitude's off a little bit. And then she also had an ear infection, which was quite challenging because hippos kind of close their ear canals when they dive. And so when you go to put things in their ears, it doesn't always get to where you need it to go.
Have you ever anesthetized a hippo? Is that something that you guys do? How's that work?
I haven't had to do hippo anesthesia because since I've been here, this is the only zoo I've been at where we have hippos. So I haven't had to do it, but Dr. Jenny here has had to do it before. And you just need a really long needle to get through their subcutaneous tissue. And otherwise, just maintaining an airway and doing the things you would do for any other animals. Important.
Yeah, I want to talk about some of the larger animals here in a second. But before I do that, I saw in your email signature, you have the DVM credential, but there's another one that I thought looked kind of interesting, which was the aquatic certification. Can you tell me what that means? What's that about?
Yeah, so it's just a certification that you can get. Pretty much, it just says you've met standards for care for aquatics, and the aquatic certification, like it covers like fish, but also aquatic birds and diving birds and aquatic reptiles and amphibians as well. So it kind of tracks along really well with my love for herps. And yeah, like fish anesthesia is really, really fun.
Tell me about that. I have a hard time picturing fish anesthesia.
Well, their gills are kind of like our lungs, and their water is kind of like our oxygen or air. So essentially, we mix up different concentrations of anesthetics with water, and then we run it across their gills. And then by changing the concentration in the water is similar to changing like the concentration for an inhalant gas. So we can keep their level of anesthesia where we want it based on what the concentrations are.
So what kind of drugs are you using? Are you mixing into their tanks?
You can use all sorts of different ones, and you can also do injectables, but they're not generally as like predictable and not as quickly reversible. So we use a drug called MS-222, which it comes as a powder, and I don't believe it's used in any other species besides fish, and some other aquatic animals will respond to it. Some don't respond at all to it. Like some crayfish they show no response. They'll actually, if with crayfish, some species, if you have it even high enough that it's precipitating out of the water, so you have your max concentration, they'll carry it around, and it does nothing to them. So we don't use it for them, but we do for fish, and it really works really well. And as soon as you switch them back to fresh water, it's kind of like turning off anesthetic gas. Once you start flushing fresh water, either salt or fresh water, I guess, across their gills, they recover really, really quickly.
What kind of analog in human medicine would that MS-222 drug have?
I'm not sure there is one, to be honest.
Really? Wow. That's really interesting. So how do you know when the fish is asleep? What are you looking at?
It's really technical. They float. um, that's not entirely true. I mean, they do float. Some of them don't float, but you see like their opercular movements, which would be like equivalent to our like respirations. You see those slow. You see their movements. They will show similar like ataxia, like a mammal would.
Mm-hmm.
It's just they're in a water column, so they won't maintain their place in that water column.
So if you're doing a procedure, I guess, are you doing like a removal of a tumor or something? Are you doing that under the water, or how does that work?
You usually put them in like a foam wedge and submerge them mostly in the water, and then have like a tube going into their mouth and across their gills. And so their body will stay mostly in the water that they're in, but the incision site will be out. So things like mass removals or like coeliotomies, we see sometimes oophoritis in our female fish. And so essentially you just spay them.
Oh, okay. That makes sense. Is there such a thing as a fish that would be a bad anesthesia candidate?
Yeah, so there's horrible anesthesia candidates that are a pain in the butt. So things like, there's two kind of groups that come to mind. One are any of the fish that can breathe air, because when you put anesthetic, you put MS-222 in the water, then they come and gulp air and they don't go to sleep. So that's a real pain in the butt. So those guys, sometimes you have to use injectables along with the additives to water. And then the other ones that are more challenging are the fish that are like ram breathers, like some of the sharks, where they have to be constantly moving. So sharks and rays, which we don't have sharks or rays here. We've worked with some at the aquarium. We have a really great relationship with the aquarium here too. But in Fresno, we had a large number of rays and some sharks. And so they have to constantly be moving. So we would be just increasing the flow across their gills.
So why do they have to constantly be moving?
They don't have a great way of respiring. So to move, they essentially like open their mouths and move and ram the water through.
Oh, okay. Wow. I imagine that would make it really challenging to anesthetize them.
Yeah, it works out pretty well as long as as long as they're moving around when they're falling asleep, and then once they're sleeping, you just need to make sure that the flow across um, their gills are out their spiracles.
Are there any like disaster situations that can happen in a fish anesthetic?
Yeah, so sometimes they can get too deep. They can have all the same like negative, like adverse effects that other species can. Um, I haven't actually ever, I've anesthetized tons of fish, and I haven't had any complications. They seem to do pretty well with MS-222.
Oh, that's good. Okay, so let's go to the other end of the spectrum and go to the very large animals. What is it like? What is the hardest part of anesthetizing an elephant, say?
Well, a lot of so elephants of the megavertebrate species are kind of they're probably among the more not predictable as far as how they react to anesthesia, but most of them are so well trained that you can do things like IV sedations or things like that. You can do like we do have to sometimes dart them as well, but a lot of times you can do things that you wouldn't be able to do with a more wild or untrained animal. So the biggest thing for those guys is just making sure that you can establish an airway and that you can they're so heavy you need to be able to breathe for them, to ventilate them. So getting them into an appropriate position sometimes is quite challenging. Um, there's actually um, there's like a oxygen demand valve kind of thing that we use. We call it the Zubinator because Zub is the last name of the veterinarian who developed it, but it's essentially like you can force like large um, volumes under pressure of oxygen into their lungs. And so we use that if we have to. Luckily, here we haven't had to. Our elephants have been generally healthy. And when we've had to do things, we've been able to do it with sedation and local blocks. So we haven't had to do general anesthesia here in Cincinnati yet.
I read that you treated Sabu's arthritis with injections to the elbows and that you consulted a pain medicine specialist. And I was just curious if you could tell me more about that.
Yeah, so Dr. Matt Brunke is a pain medicine specialty veterinarian. He presented at the Association of Zoo Vets conference, and we reached out to him after, and we talked about a bunch of different options, everything from like giving like arthromid in the joint to stem cells to like PRP and all those things. And so we decided to do arthromid. And so he flew out here for the first time. And then we've done it a few times since then without him here. But essentially, we just do standing sedation and then um, locate the joint space with X-ray and ultrasound, and then just do an intra-articular injection. We also collected synovial fluid for cultures and like sequencing and cytology, things like that.
So I'm really fascinated by the positioning aspect of it. How can an elephant safely lie down? How does that work?
Well, for us, when we're doing our sedation, we hope that they don't lay down. When they do, you just need to not be under them as they're laying down, which sometimes is easier said than done. I mean, it's easy enough to get out of the way, but and they usually show signs that they're going to lay down when they're sedated. But the goal is to do it in standing through standing sedation. Sabu actually did lay down, and we have a kind of like it's a thing called like a tripod, but essentially it puts a sling under him and then uses leverage to help support weight. So we're able to kind of hold him off in a normal, like, or in a position that he could breathe easily, even though he was sedated and he had his elbows actually flexed. And so for him, it made it really easy to give him his joint injections because his elbows were in a wide open, easy space. When we did one of our other elephants, she stood well, so her sedation didn't get as deep and we didn't need to sedate her more. And so it was a little harder to find her joint space, but it was a lot easier because she never, from a sedation perspective, because she never actually laid down.
Wow. So how many people are in the room for something like that?
Well, we do it in their holding space. You probably have maybe 20 people right around them, and then another like 20 people or so ready to respond if there's any problems. We also for Sabu, because we know that he has some elbow arthritis, and so we didn't know how well he would get up if he went down. So we actually removed from our elephant trek building, we removed one of the skylights and had a crane brought in and lowered down so that if he were to go down, we could lift him up off the ground with a crane. Luckily, we didn't need to do that, but we had it in place just in case. There's a lot of planning that goes into those procedures because you don't ever want to be in a situation where you just can't get them up.
I've had some heavy patients personally, but I've never thought about
bringing in a crane.
That's amazing.
That'd be really embarrassing if you had to bring in a crane.
Let's talk about some of the cold-blooded animals and penguins and the reptiles and such. I remember seeing on your board earlier today that you're going to do a CT on a penguin. Is that right?
Yep. So he's a little penguin who has a beak injury. And so we're just doing a CT to see whether there's bone involvement. His white cell count's been normal and he's otherwise seems clinically normal. So we think it's primarily like a trauma, like he got it smacked on something, but we want to make sure there's not any infectious component or anything like that. So we're going to assess him more today. So for them, because they have dive reflexes, just like the pinnipeds, like seals and sea lions and things, and obviously like cetaceans all do. But you pre-med them so that they're you don't need as much gas, and so that you can maintain a more smooth level of anesthesia. And they're actually pretty. I mean, the penguins are pretty simple for anesthesia.
What's it like to intubate a bird? What's different about it?
They're easy. So birds and reptiles generally, their like glottis is pretty easily visible, and so it's way easier than any primate or way easier than a person.
What's the most challenging animal to intubate? I imagine there's probably a few.
Yeah, I would say like the megavertebrates are, because you can't see and everything's by feel. So you might be up to your shoulder in something's mouth trying to feel for the glottis to then pass a tube in, and the tube's like bigger around than your arm. So that's always fun. I can show you after we chat. I can show you some of the tubes that we use.
I would love to see some giant endotracheal tubes. That sounds awesome.
Yeah, we use everything from we'll use like a 24 or 22 gauge catheter for some like made into an endotracheal tube, like an IV catheter for some of our really small patients, like small lizards or snakes or things like that, all the way up to the endotracheal tubes for elephants are as big around as my forearm.
Oh, wow.
Or bigger.
So we spend all day in anesthesia trying to keep the patients warm. Is it ever the opposite problem when you're taking care of the penguins and such?
Yes. Yeah, actually, that's a good question. So we spend a lot of our time trying to keep patients warm too, but even some of the mammals that stay warm become hyperthermic because especially most of our animals here at the zoo are really well trained. And so they'll come up in position for hand injections and they fall asleep, and there's not a lot of excitement, but some of them aren't. And so those guys, you worry about hyperthermia. And then, so you need to make sure you're monitoring temps there. But then a lot of our cold weather penguins actually become hyperthermic if they're not kept cool under anesthesia. So we actually have cold water blankets and things that we sometimes use and we monitor their temperatures to make sure they're not hyperthermic.
So my understanding is very limited of how bird respiration works, but I understand that they have air sacs. That's a little bit different. What does that mean practically when you're trying to breathe for a bird?
You generally still like use manual respirations just like you do for a mammal.
Mm-hmm.
But one kind of cool thing, I guess, is if they have like an upper airway obstruction, you can just put a tube into their a coelomic air sac and then breathe them through that way. So while you're scoping or trying to get an obstruction out, like sometimes a seed hull or something gets stuck. So you can do that. But yeah, you also have to be a little careful when you're like restraining birds because they don't have a diaphragm and their keel has to be able to move out to expand their air sacs to move air through their lungs. So their lungs aren't like ours where air goes in and then goes out. Air actually moves all the way through them, goes through the air sac, circulates, and then goes back out. And so you can't compress their body. They can't breathe then.
I was reading something about where you did regional limb perfusion on a little blue penguin. Can you tell me about that?
Yeah, so we've actually had to do regional limb perfusion on a bunch of different species, but penguins have a really high incidence of like pododermatitis, and one of our little blue penguins actually came from another institution a long time ago, and long time being like 4 years, not like 40 years.
Sure.
But she actually had osteomyelitis, and so we were doing pretty frequent regional limb perfusions. And so you just put a tourniquet on, catheterize her, give like amikacin or whichever antibiotic you're choosing, let it sit for about 20 minutes, and then release it. And that way you can give a systemic dose, but keep it mostly localized to a small area.
That's really interesting. I didn't know that you were getting that in depth on one animal. That's really great.
Yeah, we have a pretty crazy preventative health program here where every animal in the zoo is on a schedule. So depending on like their risk factors for anesthesia or where they're at training wise, and what the species is, anywhere from 1 to 3 years, every animal in the zoo gets an exam, blood work, x-rays, ultrasound. If they're small enough, a CT, something, we do all of our diagnostics anytime when they're sedated so that we don't have to sedate them as frequently. And so we catch things really early. So we don't actually have a lot of surprises, which is nice.
Oh, that's great. So when I come to work every day, I'm not working with patients that I think are likely to or could kill me, which is different from what you do. So let's talk about if you have to anesthetize a tiger or something like that. What is your theory of mind when you're going to set that sort of thing up? What do you have to think about?
Communication's probably the biggest thing, and just making sure that everybody knows their role, and like so we're very efficient. Um, Luckily, most of our like super dangerous animals are trained really well as well, and so our tigers will present their backsides for hand injection. We'll sedate them. They'll actually let us get blood from their tail veins too. Our technicians are really good at it, and so sometimes we can have pre-anesthetic blood work on them, which is really nice. Actually, all of our big cats at the zoo, so we can check their organ function before we anesthetize them most of the time. But pretty much we give an injection of induction drugs, which usually a cocktail. Oftentimes we use like ketamine, medetomidine, or dexmedetomidine, butorphanol, midazolam, some combo. Sometimes we also have to use ultra potents like atorphine or carfentanil or something like that. But then once they're sleeping, one of the veterinarians will go in and just assess anesthetic depth. And they're usually like sleepy enough that they're not going to get up and try to get you. And so sometimes they need a little more as a top off, or sometimes we'll give propofol or Alfaxan or something to get them a little sleepier. And then we'll intubate them and maintain them on gas. And so we just really monitor their anesthetic depth. There's always someone that's committed to that being their only responsibility, is to make sure that they're under a safe anesthetic plane that's safe for them, and also they're not going to wake up and hurt anyone.
Right. I remember that being something that was definitely on my mind when I was taking care of the two gorillas that I've had the opportunity to take care of, was the safety of everything. And I did feel safe the whole time, but my own nervous system was certainly on high alert when I was transporting a gorilla in a van and masking with isoflurane.
Yeah, that's probably the transport from their habitat to the hospital, and then back from the zoo or from the hospital back to their habitats. Probably the most risky time. Probably the initial transport's the most risky, because if they're being carried and jostled around, sometimes they get stimulated. But we do things like for our apes, we wrap their hands so that if they do become light under anesthesia, they can't grab onto anything. Usually we have catheters placed, or at least a mask with anesthesia, so that we can get them deeper if needed. But and we usually have we often have people from our public safety team escorting us so that if there was an emergency, they could respond quickly. But we're just really careful. And obviously, human health and safety comes before anything else. And that's kind of how it is across the zoo as a whole. Like the human health and human safety has to come before animal health, and then that comes before any kind of property damage or anything. So it's always humans, animals, then property.
I do something sort of similar with some of my human patients. When people have really long fingernails, I will sometimes wrap their hands in a blue towel and wrap tape around them as they're waking up so they can't scratch at their eyes and prevent corneal abrasions and stuff.
Oh, I never thought about that. I normally thought, well, I guess I don't have long fingernails, so I guess I wouldn't have to worry too much about doing it to myself. So I've never woke up with my hands wrapped, but I'd be like, what did I do? What did I do
It's
to
usually for those
myself?
really long, sometimes very sharp fake nails that
Ah.
you have to worry about. I call it kitten mittens when I
Oh, yeah, that makes sense.
wrap them up like that.
Yeah, things you learn.
So there's other types of animals that can be very dangerous too for different reasons. Can you talk about super venomous snakes and what that's like?
Yeah, so because I've had reptiles my whole life, there were points in my life where I've kept a lot of venomous snakes, and I don't anymore because I feel like it's probably not the best plan for me. But so I'm very comfortable with them. I don't think that my heart rate increases at all if I'm working with a cobra or something.
Wow.
But our reptile keepers are really, really skilled, and they'll use like hooks and things and get them into an acrylic tube so that they can't bite anyone. And then we'll use injectable anesthetics to get them sleeping if we need to do a surgery or something like that. And then we will intubate them. You don't put your fingers in their mouth to intubate them. You just always use tools. And then once the tube's in, we'll tape their mouth shut over the endotracheal tube. So then it's not likely someone's going to be bitten.
Wow. Uh, I've read that reptiles can take a lot longer to wake up than people. What's the differential between wake up times between different species? How does that work?
Oh, yeah. That's a good question. So birds generally wake up really, really quickly. I should say before that, and we oftentimes use reversible anesthetic protocols because we want our animals to be able to recover pretty quickly.
Sure.
So birds wake up very fast. Oftentimes from the time when they're off of an anesthetic gas till the time they're awake and standing and mostly normal is a matter of a couple minutes.
Wow.
It's really, really quick. And then I would say some of our like higher metabolism mammals wake up pretty quickly as well. After reversal, usually it's like 5 to 10 minutes and they're like getting towards normal. Our reptiles, a quick wake up is like an hour. And a prolonged wake up could be 12 hours.
Oh, wow.
And so it depends a lot on what anesthetic protocols were used and whether reversals are available or things like that. There are reports actually of reptiles being given high doses of ketamine or telazol, which is teledamine and zolazepam, previous to some of the newer cocktails where they were given pretty high doses to get them sleepy enough to do a procedure. And sometimes those animals would sleep for like 2 to 3 days. But as long as they're like breathing on their own and you can maintain their temperatures and stuff, that was like 15 years ago, a lot of them, and they would still live and do fine. It's just really nerve-wracking. I never really had any that lasted that long, but they are reported.
Spontaneous ventilation, obviously a really important piece for a lot of your animals, I would think. Do you use neuromuscular blockers in any of your veterinary anesthetics?
We don't often. The only procedures that I've been in where that's been used has been for more invasive procedures in like our pinnipeds in a previous zoo. So they would be on a ventilator sometimes. But here we generally don't need to. And it's a little bit interesting too, because we talked about differences in recovery times, but things like what the stimulus to breathe is, for mammals, a high CO2 makes you spontaneously breathe. But for reptiles, low oxygen is the stimulus for breathing. And so when you have them intubated and they're receiving 100% oxygen, once they get to a reasonable surgical plane of anesthesia, they stop breathing. And so those guys always require manual ventilation throughout a surgery if they're actually at an appropriate level of anesthetic.
Can you forgive my ignorance, and I'll ask you what a pinniped is?
Oh, sorry. Yeah, those are like seals and sea lions.
Oh, okay. I gotcha. One of the things that I am very used to is putting on anesthetic monitors, and they're pretty standard across human anesthesia, but I imagine it's completely different in all of the different species that you anesthetize. What are some of the different types of monitoring that you do? Is there anything that we would recognize in human terms?
Yeah, I think mostly we use all the same things that you guys do. We monitor like SpO2 and EtCO2 and blood pressure and heart rate, respiratory rate, temperature, EKGs. How we get those are sometimes a little bit different. So, and positioning, like for an EKG on a snake, might be a little bit different than for a person. But
How do you
um,
position an EKG on a snake?
so you essentially pretend they have legs, and um, and sometimes the clips will work. Sometimes like stick-on leads will work, but oftentimes we use a needle through their skin and then connect the clips to the needle, and so essentially you're just like pretending that the needle's a leg or an
Wow.
arm.
And how would you measure SpO2, for example? Do you just, where would it go?
So that depends a lot on the species, but a lot of our animals, we put it on their tongues, sometimes a finger, sometimes a prepuce, sometimes a vulva. Like sometimes you have to be a little inappropriate where you're putting the probe, but sometimes there's rectal probes that work pretty well. Um, it really depends. You can put it like between the mandibles on a beak on some birds, like that connective tissue. Sometimes that'll pick up a SpO2 pretty well.
Wow. I have put SpO2 probes in some interesting places, but not necessarily places that you're mentioning. I've done the nose and the lip and the ear, and in addition to, of course, the digits. But
Mhm.
that's really interesting.
Yeah, we use nose sometimes too, and lips and ears, and sometimes fingers, and it just depends on the individual.
So another thing that's a little bit easier to monitor in humans is when they wake up, they can tell you if they're hurting or not. How do you monitor that in your animals? How can you tell?
Some animals will actually like there's a huge range, right? So some animals will actually pay specific attention to an area. Some will just favor it. Even some like reptiles where pain is still I mean, there are still people out there that don't think reptiles feel pain, which is absolute crap. Um, but they just express it differently. So
Hmm.
a snake, if it's painful along an incision, when it crawls, it might just pull weight off of it or like kind of shift their position a little, so they're not crawling on that site. A lot of our animals just hunker down and if they're uncomfortable, just are less active, and so that's a thing. There's grimace scales, so you can see like facial expression on different animals.
Hmm.
Sometimes keepers really monitor their behaviors and eating. There's a lot of different symptoms or signs, but
How are you treating something like post-operative pain in a fish versus a gorilla? Is it are- what are you, how does that work?
it's really variable. So
I imagine.
yeah, so like the just pharmacokinetics of the different drugs are so different. We do use a lot of things like a lot of NSAIDs and a lot of opioids, and we use like gabapentin and amantadine and things like that as well. But um, like a good example would be, for most of our mammals, hydromorphone dose is like zero point 0.1, sometimes up to 0.2 milligrams per kilogram, something like that. Um, for reptiles, in general, the dose is 1 milligram per kilogram. And then there's differences like oftentimes people will say, well, what drug do you like for reptiles? That's like saying, what drug do you like for mammals?
Sure.
So, like an elephant and a human are as closely related as, um, like a snake and a tortoise. Um, so, like, that's probably not exactly true if you look at the like tree, but same right idea. Like there's a huge difference between all the different species. Just because they have scales doesn't mean that you can treat them with the same drugs.
Wow. How much of what you do is veterinary medicine that is known and published about versus we're just going to try this? Maybe nobody has done this before.
Oftentimes it's something that's known in another species. So we there's a ton of data out there on domestics and on production animals and things like that.
Sure.
And so and there's the body of literature in zoo medicine is rapidly growing, and so we're constantly learning new things, which is amazing and lets us contribute as well. Which is a great feeling. It's one of the things I love about my job here is like I can feel like we make a difference outside of the zoo proper. But I would say like a fair number of the things that we do are known in other species, and then we have to extrapolate.
Yeah, that makes sense. So I imagine that there's some times where you decide to not do an anesthetic, that it might be too risky. Can you talk about those situations and what your thought process is around the ethics of what to do in those types of situations?
Yeah. In general, everything is a risk assessment. So every procedure, it's like is the benefit of doing this is it going to outweigh the risk of this procedure? And so we have as different as this is, in human medicine, euthanasia is not an option.
Right.
And so at least not here. And so for our animals, if something is sick enough that we're worried that they're suffering or that they're not going to improve, we can do things like plan an anesthetic procedure to see if there's something like that we could make a diagnosis that could fix the problem, or if they need a surgery that we could fix it. But while they're under anesthesia, if we find that there's something we can't fix, we can opt for euthanasia. And so, if you find like metastatic tumors and it's not an animal that's amenable for like chemotherapy or something like that, we could opt for euthanasia so that they don't have to suffer. And so we don't usually shy away from the risks of anesthesia in those situations where the candidate's not great, because if they're not a great anesthetic candidate because they're sick, that means that there's something significant that we should try to address so that their quality of life isn't impacted.
Yeah, that makes sense. So let's say one of our residents was really interested in getting more involved with the zoo and getting more involved in this sort of anesthesia. What would you recommend that they do?
Just get involved with the program with our apes. It's kind of a weird, like, veterinary medicine has progressed a lot, and so there's a lot of specialty veterinarians. And so, based on our Practice Act, we're supposed to involve veterinary specialists whenever appropriate. And so, we don't usually have human anesthesiologists come for procedures on animals that are more similar to something that would be seen in
Sure.
veterinary medicine. But I would argue that there are some veterinary anesthesiologists that have done a ton of ape work. They're kind of few and far between, so like you guys anesthetize in quotes apes every day.
Sure.
And so you're very, very knowledgeable, all the newest things, and so we're really comfortable working with you guys for those cases, because you're more skilled in it than most of the other people that we could find.
Yeah.
We really appreciate it.
Well, we really appreciate the opportunity. It's something that I consider one of the top experiences of my life, was getting to take care of the gorillas here, honestly.
Yeah, it's cool. I found myself more involved in like human, like public health, One Health kind of dimension a little bit. And so it's probably similar. I think that stuff's really interesting, how the human population is kind of monitored and screened and like public health things. And so it's probably similar. I think it's really interesting to me doing that because it's kind of outside of the things I do every day. And
Right.
You guys aren't anesthetizing bonobos or gorillas every day.
Yeah, right. Before I let you go, I'd like to ask you about your own personal style points. What style points or points of personal preference have brought you success both in and out of the operating room?
That's another thing where I think communication is, you can't really overstate the importance of communication. So I like to goof around. I like to have fun. I don't like to just be serious all the time. I'm serious when I need to be serious, but um, I think having, we're all dealing with, critical patients and complicated situations and things. And so just being lighthearted and having like a great relationship and open communication with your team is probably more important than any knowledge you could ever gain. You can always find someone that's more intelligent than you, right? But you need to be able to communicate with that person if you want to get a good outcome. So I do think that above all else, like, being able to work as a team and communicate effectively makes for better procedures.
Mike, thank you so much for joining us. I really appreciated your time.
Yeah, it's a good time.
Thanks for listening to another episode of Style Points. To address the elephant in the room, the picture associated with this episode is of Mike and I posing with an elephant-sized endotracheal tube, size 45 if you're curious, a little bit bigger than the 7.5 we use in the adult human population. If you enjoyed the show, please consider leaving us a 5-star rating or a written review. It really is the best way to help other people find the podcast. You can always reach me at stylepointspodcast@gmail.com. Take a deep breath. Open your eyes. We're all done.